very much to BICC organizer to allow me to participate in this elegant conference. I'm very happy to come back to Bangladesh and being very happy to be part of this collaborative or multidisciplinary talk on the breast cancer. Heard and learned from Dr. Fareed Ahmad and Dr. Khalid Hamid, and so surgery and medical oncology part is discussed, and now we'll talk about the radiation part of the breast cancer management. So my other colleagues have already mentioned something about that this cancer is the most common cancer in not only in Bangladesh but entire region. I worked in Middle East and some other countries, and I found this is the most common cancer. So any effort to de-escalate or to enhance the outcome is important to the community and to the country. So today my topic is about hypofractionation of radiation. So this is more aligning with the theme of de-escalation of the treatment. So it's not that we should always try to de-escalate the treatment. There are times when we need to escalate the treatment, and there are other patients where we should de-escalate the treatment, and that is both is important equally. The important challenge in the past was to select the patient who should be de-escalated and the other one who to be escalated. So my theme will be more for de-escalation, and I would take your attention for this slide, even though it is a busy slide and there are lots of writing in here, but this will be the base for all the talk. I will go forward, and if you grasp here what I'm talking here will be good enough to get the other slides go faster. So we all know that we were treating breast cancer as an adjuvant radiation treatment, most commonly surgery or neoadjuvant chemo or chemo adjuvant chemo. So radiation in the sequence comes the last treatment for the patient. It can go along with the hormonal treatment or Herceptin treatment, for example, but usually it's not given with the chemotherapy. So in a sequence, either neoadjuvant chemo followed by surgery, followed by, if required, adjuvant chemo or radiation. So with this radiation, most common schedule in the past we used was 50 Gray 25 fractions, where we were using 5 weeks of radiation every day for a few minutes. And this was even sometime further go forward by a boost, no boost EORTC trial, where the further radiation for the boost actually enhanced the outcome. So it became 33 session of radiation, which is about 7 weeks. So that's very tiring for the patient. But anyway, this is the standard where we started from. And then there studies happen and they try to shorten the radiation treatment, but they don't want to reduce the outcome and not want to give more toxicity. And therefore, START B trial come where they tested 15 sessions. This was also can be with 5 sessions of radiation for the boost. So it's about half of the treatment from the original treatment, and that's improved. And the outcome was similar, and toxicity was actually decreased in some sense. So that was another one. Then Canadian study for moderate, so we call it moderate hypofractionation. So if it is standard fractionation, but when we increase the dose each fraction and overall total dose and duration is reduced, we call moderate hypofractionation. But if we do extreme reduction of the number of fraction and give very large radiation, it's called ultra hypofractionation. So when we are treating full breast and we're doing standard, then I talked to you about moderate hypofractionation, about 3 different doses. And the new addition come into it that we were giving the boost sequentially. First we finish external beam to the all breast, and then we give the boost, so it become longer. So then the studies kick in, and they did the combination of boost and full radiation concurrently. By doing this, with the duration actually reduced, but the outcome did not change because we deliver the same radiation. Then we think about, even some people start thinking that 3 to 4 weeks is long enough. And we start looking as someone who knows the cricket match. We were playing the test cricket, then we come to one-day cricket, so it becomes short and people have the interest. And then we come to 20-20 match, which like really 20 overs to each team. So for that, we thought actually, can we reduce this further or not? That specifically in the COVID days, when treatment was very difficult. So we want to be the shortest one. So this one study come from UK, fast forward trial, where they give only 5 sessions of radiation to entire breast. And that's actually was a win-win for everyone, because all we need to prove that this is equivalent treatment. And if you prove that, that means convenience for the patient and resource utilization is the best. So it will be the winner. So this was to the full volume of the breast when I'm talking to you with the boost or no boost. Then the other de-escalation direction come, that do we need to treat the entire breast, or we just treat the tumor and some healthy tissue around? And there we called partial breast irradiation come. So first trial, which was low UK import trial, I will show you the slides later, but as I said that if we discuss all this here, then we can go flip faster. So low UK import trial, they say they actually did the same dose as moderate hypofractionation, as I mentioned you above, the 3 moderate hypofractionated doses, but they give it to a small volume, only tumor around tumor. That was so easy. Anyone who is radiation oncology would know that, because when we treat a small volume, the doses to the lung and heart and contralateral breast is very, very low. And the side effect is not there. And sometimes patients ask us, are you really treating me or not? Because no toxicity or side effect. So then after that, we come with the then this partial breast irradiation, there are multiple studies have happened. I listed in here, but more commonly used nowadays is the Florence study, because they have long-term data. Now with this, we can move forward, and then we can talk individually about these things. So this was the first landmark, big trial where we talk about, do we need radiation after surgery or chemotherapy? So this is the Oxford meta-analysis, very famous, 20 years from now, past. And actually they set up the stage for that radiation should be part of the treatment for most patients. In some patients you can escape. So when radiation we know is established, we want to give the least side effect and most tumor gain. And with this, therapeutic ratio is a very common one, which everybody know about. So we try to gain. And for that reason, when we know that, we heard from Dr. Farid that, we are going to more and more conservative surgery, partial surgery of the breast, axillary, instead of doing full axillary dissection, we're now doing the sentinel node biopsy and reducing the lymphedema. So they are doing their job. Then we heard from Dr. Khalid that they want to give for triple negative, which is very aggressive tumor, higher treatment. But on the other hand, the lower end were like luminal A type of patient, we are de-escalating the treatment. So the de-escalation is going in surgery direction, chemotherapy, then also same thing for the radiation, what we are doing. So why and how we can do that? So people who are in radiation oncology, they know that there is something called alpha beta ratio. When I started my residency, I was told that alpha beta ratio is 10 for the cancer, which is for most of the cancer, and they applied to everyone. And that's where they calculated the radiation dose, how much radiation dose should go. But with the time passed, we start learning the alpha beta ratio is not same for everything. Prostate cancer different, breast different, brain different, leukemia, you cannot put them into one box. So because of that learning of alpha beta ratio, that we start moving that, okay, let's do the calculation. We start doing estimation as well. So when we did estimation in the beginning, we have a little bit incorrect but closer estimate, and now we are having better estimate. With this alpha beta ratio, if it is lower side, you can give larger dose of radiation each time in a shorter period of time. If it is lower, if high, alpha beta high, you have to give smaller doses over a longer period of time. So breast cancer fall into the group of low alpha beta ratio, means we can give larger fraction size over shorter period of time, and it will still be the same outcome and will not, hopefully not increase toxicity. So then this is about the hypofractionated trial I just mentioned to you. UK was a START B trial. Whelan was from the Canada where I worked, and we get this doses, and also UK START A trial. These are all published, and that's how we come to moderate hypofractionation. There's something interesting come, as I mentioned to you, that we start doing the boost together with the main treatment to shorten the treatment. And this was IMRT MC2 trial. For the people in radiation oncology, they can note this trial because this is not commonly known. Since this was using 28 sessions of radiation, it come from US, and there is a insurance reimbursement issues, and therefore they don't want to go 15 session. So they come up with 28 session, but still the boost was given together. So if anyone want to follow this, they can follow this trial. However, it didn't become very famous. So I just want to bring it in here. So it was a phase 3 trial. and very high doses were given. And with this treatment, this was tolerated well. The outcome is, you can see the graph is very well. I was part of this study. I was co-investigator, start publishing. It's called RTOG 1005. This is the first volume-based radiation oncology study where we try to do the boost together and using, so here we use two techniques. We use moderate hypofractionation, so reduce the overall duration and dose to the breast. At the same time, we boost together with that to the tumor bed area. So we combine the benefit of partial breast radiation and duration radiation, still make it shorter. So this is the 15 session. When you finish 15 session, you finish the full treatment. So we were worried about, when we were going to this direction, we were worried about the side effect. We're giving too much radiation in a short period of time. Would it be toxic for the patient? And actually, over a period of time, it showed us it is less toxic to patient, because our alpha beta calculation in the beginning was wrong. Based on that, our calculation was that it may give more side effect. But when we did the study clinically, we found less side effect. So this become very common. And especially for the surgeon, something for interesting that when we were going hypofractionation, they were thinking, or we were thinking, that with the implant, if we do, the implant failure rate will be higher for shorter duration of treatment, but actually it become opposite. So this all goes to the alpha beta ratio. Because of that, this happens. So this is the how it look like, that we give sequential boost or we give concurrent boost. Hypo-SIB, another trial where they did the SIB boost, and the results published for the toxicity was very equivalent, so it is safe to have that. UK import high trial, again they escalated the radiation dose in the boost, shorter the treatment overall, and is still the same outcome. So basically what the result of all this SIB trial was, that we can do simultaneous integrated boost. It is safe, it does not increase the side effect, and the outcomes also not affected. Also, patient assessed quality of life is good as well. So this is safe treatment. And I mentioned about the ultra hypofractionated radiation, 5 session only, fast forward trial. So they give only 5 session to entire breast, and the results are again equivalent, comparable, and not increasing the toxicity. The only challenge here to apply this study is because the outcome measure is only for 5 years, while we want to look for longer outcome for the breast cancer. However, this regime is very common regime nowadays, and is being applied in the clinic because of the 5 session. UK low import trial, as I mentioned, they will be treating only the breast volume, and they spare the rest of the normal healthy tissue. They just only treated the tumor bed or seroma with the clips with some margins, and protected the lung and heart. So this was a new innovation for all of us, that we start shrinking the volume and not treating the entire breast. So after UK import low trial, when we did the 5 session, this is the rapid trial. I was part of this in Canada. This study was giving 10 sessions in 5 days. Unfortunately, this study negative, because one of the reasons was that we give very large dose twice daily in a shorter period of time, and also our planning was allowed to not to use the highest or newer technique, so it gave only 1% extra toxicity, but that 1% extra toxicity was enough to not to make this popular. What become popular is where I was not part of it, so I don't know the much detail, but however, what I read from their article is that Florence study, which is from Italy, and it is now 10-year outcome we have, and we find the results are very equivalent in this trial compared to 5 session using full breast, 15 session where we treated breast and then boost, or SIB boost. So this study, this for early stage breast cancer patients, where we can select the patient correctly, we can give this treatment. So you can see that instead of giving the whole breast radiation, I showed you low UK import trial picture there. So this is the seroma. We grow some margin, protect the skin in here, protect the heart, lung and heart, and then we treat this area. So we try to spare the rest of the breast. So that's also kind of significant improvement, and it's unfortunately in our region, this partial breast radiation is not very commonly applied. Maybe one of the reasons that many cases are diagnosed advanced stages rather than early stage, so that it would be not too much of experience of treating early stage. Second thing is we are not much aware of, and some places there are limitations of the technology. However, I would request people to pay attention and look into the Florence study. If it is applied to any patient, can be treated in 5 sessions with very little toxicity because heart and lung doses are very low. So these are the results. You can see that compared to standard treatment, there is no difference for both breast-specific cancer survivor and for overall survivor. And it's long-term data, it's 10-year data. So last patient I treated in UAE with this protocol, she was asking me, did I really receive radiation or no? Because you explained me so many toxicity and side effect, nothing happened. So I would say for the patient's sake, definitely consider if you have early stage breast cancer patient. So I would, this is my last slice, and I'm happy that I'll be able to even finish earlier. I was worried about 15 minutes, not enough to cover any topics, so I was a little bit faster. So that, so as I mentioned, that alpha beta ratio of breast cancer is low. It's not 10, it's 3 to 4. And we are more evolving into it. Because of that, we have biological rationale that we can increase the dose each session and decrease overall treatment in a smaller number of fractions, 5 sessions instead of 33. That's a big jump. This will be very advantageous for the patient, for also the resource utilization, and especially the centers which are busy. So we should consider moderate hypofractionation or ultra hypofractionation for all early stage breast cancer. For the advanced stage breast cancer also, there is one Chinese trial not commonly known. So that's also very important to know. So that Chinese trial given 43.5 grain, 15 fractions, which I discuss to my colleagues whenever possible, can be used as well. So it's not only for low stage now, it's only going for advanced stages as well. Advanced technology, if you have it, it's good, but it's not that would stop you. So partial breast irradiation, which I talked to you about, was treated using 3D technology, IMRT, VMAT, and now I'm using SBRT. If you have facility, fine. If you don't have, you can still use the technology you have and you can still deliver. But what important point is, when you do smaller volume, then you need to focus and not to miss your target. And for that, you have to have an verification imaging system where you can be careful and ensure that treatment is delivered. I would say that, as I mentioned, it is similar or improved toxicity profile. It's fewer visit for the patient. It's the lower cost, improved cosmesis, and patient-reported improved quality of life. So very few interventions in the medicine would have done this many things one time with this one jump. So I would request everyone to pay attention that patient eligible to go for moderate or ultra hypofractionated radiation. Standard is less commonly used now. It can still be used in cases which is advanced diseases. However, after Chinese trial of 15 sessions for advanced cases, that also can be moderate hypofractionation. I don't remember when the last time I used the standard fractionation, so it seems very long. Okay, with this I'll end my talk, and thank you very much.
Thank you, Dr. Nadem Pervez.